Okay, I think we're going to transition here to future state mapping. So for those of you that are strict agenda followers, I gave you a little extra time for lunch, and I hope that was okay. I don't think future state mapping will take a full hour. All right, so now we're in step 4. So we've mapped out our current or ideal state, or I'm sorry, we mapped out our current state, and now we're going to go to future state process mapping. So here we're going to map out an ideal state. So as I mentioned earlier, this is not a static process where you go do this one time and then you're done. This is really about looking at your current state, making sure it's stable. So for example, if you're here and you're doing this mapping, but you have 3 other teams back to your practice, you want to go and say, is this true? You know, are you as MAs doing these? So is it really a stable current state? Are all the teams and sites really doing it this way? So sort of checking your current state. Then you want to define your future state. And again, the future state isn't just one process. It may be trying things, it may be redistributing, and then you want to eventually define your future state and roll that out. But again, it's always good to keep coming back to our processes, our distribution of roles and tasks to make sure that we're not overburdening and underburdening teams and making sure it's working. So here are some things to consider in your future state map. And again, this goes back to the current state, but what are more proactive things we could be doing ahead of the visit? What follow-up things would we be doing in our ideal state? And what tasks go to whatever level of licensure in the future state? Also, again, going back and looking which roles are overburdened already? How do we redistribute to license? So really just stepping back and taking a look at it. If you're from a practice or a system and you want to try to add a role like care coordinator or care manager or things like that, if you have that coming, feel free to do that. I wanted to say a couple things as we transition into future state. One, and this goes back to the webinar, I think I said this during the pre-work webinar, but if I didn't, I want to say this out loud. Google did a lot of research on effective teams, and they looked at tens of thousands of data points, and they couldn't figure out a common thread among all of their highest performing teams. And they looked at gender and age and strengths, and they just kept looking at it differently and differently. And what they found was that there were 2 key aspects of their high performing teams that were true of all the teams. One was that there was a high degree of psychological safety in the team, so people took care of each other and monitored each other and if everyone was okay. And the second was, at the end of a project team time together, everyone had equally participated through the process. And again, that doesn't mean each person has 2 to 5 minutes during each meeting. It means at the end, you can really look around and say everyone had equal talking time. So as you're transitioning to, now that you're getting so skilled at these tools, as you're transitioning to this afternoon, be thinking about your quiet people. Who isn't participating? Who can you engage more? Who might be dominating? If we are dominating, we like to call it step up and step back. So if I'm always talking like Nicole Diener does, I need to step back. If I'm really quiet, let me step up. So be thinking about that this afternoon so we don't lose valuable input. The other is, in primary care practice and really specialty practice and anywhere we are today in any organization, including Health Teamworks, we all need more time and resources, right? Resources usually meaning people. And I agree with that. What I want to say is that from my experience of the 4 years in the Comprehensive Primary Care Initiative, where our practices are getting significant dollars to add resources, especially care management. So all 60 of our practices got extra funding to hire care managers. And you think, oh my God, if we had a care manager, think of what we could do. What happened is that over the last 2 years especially, there has been constant turnover in all of our practices of the care manager role. One, because their job wasn't well defined. So they came in and someone just tried to sort of stick them in. It wasn't a team process to say, what do we really need to do? How do we redistribute? Secondly, as we add resources that are non-visit people, so as we go to value-based payment and we're getting other types of payment, we're not all going to be stuck in sort of this hamster wheel of visit, 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 which is great. But in the meantime, understandably, when we hire someone who's outside of the visit, like a care manager, it's easy to make that person a dumping ground for all activities that aren't visit-based, right? Because you're thinking, well, Nicole's over there sitting at her desk looking relax, I'm going to go give her QI. I'm going to give her callbacks. I'm going to give her. So all of a sudden, they're going to run our NCQA process. They're going to be, this, and they're not really seeing patients or doing the things that they, were hired to do. The other thing that we've been working a lot on in Colorado is integration of behavioral health. So our federal funding dollars, like yours that are funding this in your practice transformation, is toward behavioral health integration. And like the care managers, what's happened with our behavioral health providers that are getting integrated into practices is that they're begging for referrals, just like the care managers are. They're trying to talk providers and teams into referring patients to them. So the other thing is we add these great resources. They may be able to help this certain level of patient, mostly complex patients. But if we sort of add them, but we don't culturally make the accommodation that we're now a different team, we have different roles, what does this mean? And we don't do a lot of engagement around it. They just become resources walking around the practice going, please let me see your next patient that has behavioral health issues, So I want you to be thinking about this because this is our 101 class, so this is a subset of a 3-day national training that you didn't have to pay $3,000 per person for, which is good. But we have a 201 class, and in our 201 class, we talk a lot about culture change management. The fact of the matter is 70% of all major changes fail because of culture, okay? So more and more, we're going to have to be thinking about each other differently as teams. And we're going to have to be engaging people outside of our 4 walls in different ways to really get to value and longitudinal health and things of this sort. So as you're working together to define your future state, keep thinking about, defining process is great. And I think a lot of practices like, give me the checklist, give me the tactics, give me, the to-do list. But really be thinking about culturally, how do we continue to change, integrate people in new ways, train them to where they need to be, because that's where we're really going to get hung up. We can't go into a lot of that today, but I just wanted to say that out loud because it feels really good to get this all defined. But again, if one of you is dominating, I'm not saying anybody's doing this because I'm not stalking you, but if anybody's dominating, other people aren't talking, be thinking about how do we continue to redefine our team and really become this equal partnership and not accidentally top down or things like that. Again, not based on my observation today, just my observation over the last 10 years or so. Okay, so now we're going to shift to future state mapping. We're going to go back to our stations, and we're going to add activities we don't have in our current state, reduce duplications, improve gaps, redefine roles. And if you run out of stickies or you need anything, come see myself or Sarah. Does anybody have any questions or comments before we transition back? Okay, so you have 30 minutes for your future state. If you get done early, feel free to come in and sit down because that gives me a good sense that you're done. Okay, let's come back together for a few minutes here. And then we're going to be transitioning into another session, but as usual, if you need to take a restroom break or a break, please do that as you go back and forth from your stations. So future state mapping. I'm going to pick on Kent Pediatrics since I picked on them. I'm just going to keep it going throughout the day. Let's hear a little bit about what you guys learned through the future state mapping and keeping current and future separate. Ooh, the cheerleader gets to talk. Yay! She actually did a cheer at her future state map, so she gets a gold star.
Well, I'm Carolina from Kent Pediatrics, and we just learned that the doctor will take some of her tasks off her list and give them to me.
Is that why you cheered? Because you got the provider's tasks?
Well, actually, we do see that we were doing the same thing over and over again. We just took those things off the list, and we found out things that we could do ahead of time. And it's incredible. When you do that for the pre-visit, it will take a lot of the time.
That's right. Yeah, pre-visit is so important. And I have to tell you, one of the things that's been so hard over the last 10 years when we start practice transformation is talking to teams about why to do a huddle. It's always, we come in at different times. We can't take the 5 minutes. We're going to get behind. But it's amazing the 5 or 10 minute huddle, the time it saves you later. So even if people come in at staggered scheduled times, taking that 10 minutes when everyone's available will save you so much time through the day that it's worth it. So more and more as we do practice transformation, as we make the shift to value, we're going to be having to invest time to save time. And that's so hard when you're trying to fix the plane, you're flying it, you're trying not to kill your passengers, but you also have to slow it down to get a late arrival when you want to be on time. Sorry, I feel like I'm on Southwest commercial, but you get the point. We're going to more and more have to slow down to go fast. We're going to have to understand each other. And based on the simulation earlier today, I think we need to have less and less staff meetings. Meaning I'm Nicole Diener and I'm the leadership and I'm going to torture you to do updates. This means let's get together and solve problems. Let's understand our workflow. Let's really set the context. Let's get everyone's opinion. So to me, as we keep transitioning forward, there are a place for updates. I'm not saying that, but more and more it's going to have to be work meetings and investing the time to keep improving things, right? Not just sort of hearing the same updates over and over again. And that's hard because how do we get those updates out? How does everybody get the same information? Good. What did others learn?
I'm going to call out our UD staff.
Oh, good. Call out people.
If I know your name, you're in trouble.
Gina, what did you learn? Over to you.
We learned lots of things. So we learned some ideas from Rosa that we could be having flow sheets for our front desk so that, basically that begins the triage, going through. And then we also helped and sort of gave ideas about burnout for front desk to, lessen that I've learned through the years. So,
Rosa, can you say a little bit more about that, what Gina just described? I'm not sure I totally got it. I want to make sure.
What we were talking about, especially with turnover on staff, and in our case, front desk are not usually clinical staff, and so you can have a very strong triage nurse, but the first person that answers the call, they don't know what to do with that call, and your triage nurse is useless. So how do we make sure that they know what are the questions to ask and how to react to the answer to map that that patient to where they need to go?
That's great.
So making it visual, like say, this is a column red, and any answer to those questions, needs to go to triage. This is yellow, and maybe they just need to make an appointment today. This is green, means, you can schedule an appointment for a day or two. So kind of making it visual for that makes a difference.
Rose is going to get her bonus later because she's also helping me again transition to the next session, which I won't go to yet, but great setup, Rosa. Thank you. Other thoughts? What about our specialty group? What did you guys solve through your future state map? This is a way to be secretly bossy. Just say, what about you guys?
We talked about trying to automate some things too, so utilizing automation for reminder call systems, not to sound like the administrator in the session this morning, but if you do have a portal, utilizing it. The reality is we probably don't utilize it as much as we could because our patient population, but sometimes I wonder if we just use that as an excuse not to use it. There were some activities that we were able to combine. We didn't have a budget, so we created a new position.
Good job. What was the position?
An insurance verification specialist that also covered the front desk for vacancies and unscheduled absences. And I think we put a lot of focus on the front desk, but then also trying to combine some of the physician activities and try to get people in the practice to function at their max capacity to alleviate some of the pressures on the providers.
Great. And we're going to talk more and more in the next session about what do we need to accomplish what we're trying to. And sometimes we have an ideal state, and in your case, since you didn't have a budget, it's like, add a person, awesome. And in other cases, we map out our ideal state and say, we don't have the resources for this, so what can we do now and what do we have to do later, right? Because, we all have an ideal state in our mind with the maximum amount of funding available. So that's a key point. Any other final thoughts about future state mapping? Did you see the value of going, sticking with current and then trying to do future instead of trying to combine? Or does anybody think, we could have combined it? Hello, hello, hello. Well, it's after lunch, sorry. Yeah, you're going to get up soon again. I don't let you sit for long because I tend to nap after lunch if I'm given opportunity. Good. So I was going to say one other thing, but let me go into gap analysis. So for those of you true QI lean people, the gap analysis is really a fishbone diagram. And at Health Teamworks, we like to use it as a gap analysis instead of sort of a root cause because we find it a friendlier way to use it. So for those of you that use fishbone as a root cause, today we're going to use it as a gap analysis. So what is a gap analysis? So there are things that fall outside of your process that are going to still get in your way of being able to accomplish your aim. And so by following these tools in order and by finally doing a gap analysis, it's going to let you identify those things that are outside a process that'll hold you back from reaching your target state. And let me say more about that in a second. There's some examples in your binder of what falls under each category. So basically, what this allows you to do is close action items to decide what you need to do before you start your process, to take the necessary steps to ensure a successful process implementation. So let me give you an example. When I started working in residency practices many years ago, and I might have said this at the training, so I'm sorry if at the 24th event, but one that really strikes me is that at a residency practices, we had an MA and resident leader working on tobacco cessation, and they went and created this amazing self-management goal sheet for patients. Patients loved it. They set quit dates. And we said, okay, MAs, you do the callbacks to get after people set a quit date to see how they're doing. So I went away feeling like, wow, this is amazing. This is awesome. We're expanding scopes. We're doing new things. And I came back to the next meeting and everyone was depressed. So then I was depressed because I thought, well, I'm a stinky coach. And basically what we forgot is that even though the MAs were willing to do that and they were excited to do that, we had overlooked, when I think of people, I think of training. And I heard Rosa say a little bit of that and others. If we're asking people to do new roles with no support or training or time to practice without being in front of patients, we're setting ourselves up for failure. So what happened is that a group of MAs started calling people on their quit date. And then when they call them, the patient would start crying and say, I couldn't quit because my husband died or my boyfriend beat me up or all these really hard life things had gotten in the way. And the MAs had no idea how to respond, right? So all of us had the best intentions and we were like, yeah, just call them about their quit date. But we hadn't prepared the what ifs and how you transfer and how you refer to other people. Another good example is we often overlook machines. I think all of these are important, but I'll give you another example. In another practice, we had this great self-management process, and we were like, oh yeah, let's create these sheets and print them off and do all this stuff, and then we rolled it out. Again, I came back feeling like a bad coach because everyone was depressed, and we only had one printer at the very back of the residency practice with 90 people. So it's like, well, that was a good idea, but if you're going to print stuff, you might need more printers. So this is an opportunity for you to come back as a group. And I'd love for Kent to talk about how one of the examples that they've already started adding. They get gold star here. They started adding to this already. But I want you to go through this. So when it comes to metrics, do we have good baseline data? Can we pull the reports? Because nothing's going to end your process faster than not being able to support it with data and outcomes. So when you're looking at MIPS measures, when you're looking at value-based contracts, when you're looking at improvement efforts, if your system can't support your data outcomes, you're never going to know how you're doing, right? So you really want to be considering metrics. You've pretty well defined the process. I don't think you're going to need to spend a lot of time together as a team on that since you've defined it so well. People, do we have the right people? Do we have enough people? Have we trained the people? Anything else you can think of people related? Machine is, point of care testing, printers, could be laptops, kiosks, things like that. Materials, what comes up for me around materials, and I'll let Kent share in a second, are things like self-management support materials. So if we're doing tobacco cessation and counseling, do we have a quit line? Do we have brochures to give patients? Can we print? What do we need to have available? And then environment. Something that comes up in environment, because I do a lot of work with the American Cancer Society, is that they don't have, a lot of practices don't have room for extra fridges for vaccines. And so when they start out on these great screening rate things, they need to make sure who orders the vaccines, can we fit them, do we have the storage, do we need a refrigerator, things like that. Environment in today's world is often a big barrier because we're stuck in the physical environment that we're in, right? We can't just demolish our building and start over, which probably a lot of us would do. but we can't let environment totally hamper us either, so we need to be innovative and creative about our environment. If we don't have a great team-based workspace, what can we create? Is there a way in the nurses station to do that? And so be thinking what in the environment might get in the way. Can you guys talk a little bit about what you already have under materials for yours?
We are a pediatric office, so of course we have the vaccine.
Vaccines, yeah.
So, and with that also comes the thermometers and making sure that they're up to date with, that they're good.
Okay.
That we have the fridge and fridge space.
So ordering vaccines, having the fridge space, all those sorts of things. Great. A generator. Good. Oh. Sorry, I forgot you were here.
My comment on materials too is to consider, this is a big thing of mine, is health literacy and readability of documents, because we're very big about, oh, we gave them this document and then it was written because it was written by us in the 12th grade level, when it should be the 6th or 5th grade level.
That's a really good point. That's a really great point. And you'd classify that under materials as well, you said, right? Yep. Yeah, cultural health literacy, very good point. Any questions or thoughts about this? So what I'm going to have you do, so this is the final activity before we finally get to set up PDSA together, an actual test of change. So what I want you to do is go and look at your future state and look at each of these, and you might not have something under each one, but think about with your stickies, what have we overlooked that'll get in the way of our final process, okay? And let's start with 20 minutes, because this may not take you a full 30, so I'll check in with you. So let's start with 20 minutes, okay? Okay, so I know it gets tiring this time of day, so I'm bringing us back together a little early, so we may get out early today. Okay, so I'm going to try to hear from groups we haven't heard from yet, so don't everybody look down when I look around. I already warned the back group, and they're already ready. So what did you guys learn around your process through the gap analysis?
Just looking more for communication,
How to bring more subscribers to help with time, patient education, providers, more staff, equipment, process of moving higher the lane with zone visits as our goal.
Great. So you guys look like, that's why I wanted to call in your group, because it looked like you found a little bit under every category. So you see the value of stepping back and saying, okay, we've defined our process, we have our tactical approach, but what are other things outside of process that might get in our way? Thank you for sharing. Great job. Others. I don't think we've heard from your group, have we? Look at, they all are trying to look away from me. Like, she's not looking at me, is she? What did you guys talk about outside of process through your gap analysis?
She's really avoiding eye contact.
I know.
She's got it.
Did you discover anything outside the process?
Well, we were talking about increasing the usage of our patient portal and maximizing patient engagement and enrollment. And we took a step back and said, let's just start with enrollment.
So enrollment in the patient portal. Okay.
And then once they were enrolled, our goal was to increase the interaction between provider and patient with our goals. So just in our fishbone, some of the things that are our limitations are the patient materials that are available in Lightroom. So
Not liking the patient materials is a common problem, right? And that's where patient engagement can really come in. Have one help you create it, right?
And that's one of the things. And then the other is to make sure that the app is up and running and useful. And how will that be coordinated across multiple sites? And we recognize that there may be a gap in a person. We do have a budget, unfortunately.
No adding staff.
I was dreaming.
A specialist.
Yeah.
So just someone to coordinate all of the sites and particularly someone because if there are too many chiefs and not enough Indians, nothing ever gets completed. So making sure that somebody is responsible and who's responsible and empowering those to be responsible.
Wow, that was a lot of powerful points. One that I want to call out, because patient engagement is a future module, but so important. And patient engagement from several ways. One, in their own care, obviously, which is an ongoing thing. And I heard somebody say, we need to really be educating our patients. I heard that a few times. We need to teach them. And truly, we do need to teach our patients how to be different and how to be partners. So there's partnership in their own care and setting goals and doing self-management and all of that. And then there's patient engagement and quality improvement, which is one of the biggest catalysts to quality improvement I've ever seen. We didn't incorporate it today because we only had a limited amount of time, but I'll give you a quick example. I worked with a residency practice on a really cool chronic care management program for diabetes. And they designed the whole thing, and it had new functions, new roles, and it was really comprehensive, and we'd done all these tools, and we felt really good about it. And then we rolled it out. And part of the process was that each patient with diabetes were going to get what was called a diabetic passport. So it had different stickers and they different activities. Anyway, it had all this stuff going on. And then we started this patient, family, and advisory council later on, like 6 months after we started this process. And it was patients with diabetes to start. And so we said, how is the new awesome chronic care management program going? We were all proud of ourselves. And everyone was quiet. And I was like, oh no. And so we said, no, really, how do you feel about it? And one of the gentlemen said, well, I think of getting a passport to go do something really fun and go to, a different place I've never been. Diabetes is not that for me. And we were like, really good point, But had we learned that lesson way back, we wouldn't have created this whole great program. And I know engaging patients is one of those weird things on multiple levels. One is, well, we're all patients. We may have had geriatric parents that we've taken care of, other family members, or ourselves had experience as patients, but it's different engaging our patients in this capacity. And two is, sometimes the feeling is, well, we've got to get our house cleaned up before the patients come in. We can't let them know this is wrong and that are wrong, when it's actually the exact opposite. When you engage the right patients in focus groups, advisory councils, on your team, you learn things you never would have learned, and you speed up your process. I might have given this example, but one of the other biggest lessons learned, besides empanelment and risk stratification, which is part of our post-work webinars, that this group learned from me in Phoenix, this 23 practice group, is they had all these ideas for improvement, and they ran retreats, and they had engaged executive leadership and practices, and they'd come up with this really great plan. And I said, well, what do your patients think? Well, I don't know. And I'm like, well, are you willing to run like 3 focus groups and find out? And it turns out that one of their greatest plans was that they were going to expand access hours Monday through Friday to early morning and late day. And these were Medicare patients, and they all wanted Saturdays because their children could bring them in. So that was one plan that just totally blew up. The other is, through all these retreats, we heard, well, we can't really engage more mid-levels or nurse practitioners, PAs, because our patients don't see them as physicians and all this stuff. And we went out, and the patients were like, we don't care who we see as long as, care is supervised by a physician. And we were like, oh, a cultural issue came up. So we make all these assumptions, and we try not to be provider-centered medical homes or practice-centered medical homes. But then, when we only have our perspective and not the patients in an ongoing, meaningful way, that can happen. So just a plug for that, and that content is to come. What else did people learn through their gap analysis? What other things came up under your different areas? Any other magical moments? Jim?
Well, there's obviously a lot of things that can affect what we did this morning up on top there. So, having reliable equipment, obviously, for like a scale or a scanner has to be reliable. That can affect anything on top. But I think the thing that or at least I think the thing that we would probably value the most would be something like cross-training. Because, just because one person isn't there one day doesn't mean you close the clinic down. So, your staff has to be cross-trained effectively to where you're able to do anything else else up there at any given time. But if they're not, then obviously that's going to hinder your practice success. So I guess cross-training is very important.
That's a very important point, and none of us want single points of failure. I worked with a nurse from the Air Force, and she was a practice manager, or a program manager at Health Teamworks for a while, and she's like, you never want single points of failure. And she kept saying that about Health Teamworks, about practices, but it's hard because we train an MA on doing a certain thing like EKGs or whatever they're doing, spirometry or phlebotomy, but when that person quits or they're gone, everything falls apart. So it's not only how do we cross-train people, but how do we give them enough exposure that they are not asked to do it once a year, so they were trained a year ago and they're like, I don't remember how to do that. And that's hard. Again, it's hard to be disciplined and step back and say, what training do we need? And when I think about repurposing staff meetings and other types of meetings and potentially huddles, instead of talking about things, let's train people on it, right? We might say, well, we need phlebotomy. Well, let's have that training in that session, right? So that's a really good point. Any final thoughts? We're running a little ahead. Yes, Rosa. I'll pay you later, Rosa.
No, but as we were talking about, materials, environment, machine, and people, and sometimes we said, well, let's hire these people, and you haven't even noticed that you don't have an office to put them. You have a computer for them to work on. Let's add, X amount of computers or printers, and then your environment doesn't support, and then you already have too much, and now the system starts crashing, and it just pushes you back instead of forward. So doing the analysis of whether you hire more people or equipment, can your current, environment support that as we move forward? And then always having a backup plan for when the technical pieces fall apart, because you still have to continue to see patients. So, the staff knows that if we don't have the EMR, where the nurses need to call the pharmacy and get the medication list or go to DIN and pull the last test results. How do we continue to move as the technical components fall apart?
That is such a good point, and we've run into that a lot with integration of care management and behavioral health, because not only do they need space, but they need HIPAA-compliant space, right? And how much of that do we have left over outside of our exam room? So that's such a good point. Environment, like I said earlier, is one of those that's the hardest to change, right? Because we can't just go redo our space. If we were going to go and do our practices today, we'd do them differently, right? We would have a different space. We'd have more open space. We'd have HIPAA-compliant, counseling space. We'd have potentially self-management group space, things like that. So how do we be realistic about what we can do in our current restrictions, including environment, is a really key point. Great point. Okay, good. Well, I think that we're going to transition into break now. So let me just orient you to the rest of the afternoon real quick. So we're going to come back together at 1:30. So we're running 15 minutes ahead. So we're going to have you come back at 1:30, and we're going to take a break right now. And Sarah and I are going to run around and set up things at your table for a fun activity. So with the model for improvement in PDSA, raise your hand if you've ever built a pasta tower out of spaghetti and marshmallows and things like that. Ooh, we have some people with advantage. Okay. So we're going to teach the model for improvement in PDSA. We're going to build a pasta tower and do a competition. And just so you know, there's no arguing with the judges about who wins, because we're going to be scoring when you're at your stations, because people yell at me if they're watching me. They win. The table who wins gets a bag of chocolate. And then we're going to actually set our final PDSA together. So that'll be our final activity at the station. So as you can see, we've gone through the tools, and then the outcome should be what's our test to change. All right, so with that, we're going to take a break, and we'll see you back at 1:30.